with us, we have Disha Dixon and doctors Donato and Luber, who are going to share some valuable insight with us about an incredible street medicine program that they've launched to help provide healthcare for some of the most vulnerable people within our community. So without further ado, Disha, I'll turn it over to you.
All right, good morning, afternoon now, 5 minutes. And thank you for the opportunity to speak about street medicine. I think my team will agree that anytime we have the opportunity to talk about this program, we take that opportunity. But before I go into some of the slides I prepared, I want to introduce our newest team member, Darla Harris. Give us a good wave, Darla. She is our street medicine case manager, and she's helping us to kind of rebuild the program, put in some standard operating procedures, and then in the next few months, we'll really dig into care coordination and ensuring that our patients are following up on appointments and medications and things of that nature. But Darla has joined us, has it been 4 weeks now, Darla? Almost 4 weeks, yep. So I'm going to share my screen and go through just a few slides. Let me know when you're able to see the screen. You can? Okay. So the basic premise around street medicine is to provide equitable care to homeless and housing insecure patients. Here we go. Okay, so I always like to start off with, what do we mean when we say homeless? Because for different people, that can mean different things. And so how we define it for street medicine is essentially people, if they're living places where it's really not meant for human habitation, but also where people are living in transitional or emergency housing, if they're not sure night to night where they'll be sleeping, so couch surfers, families with children or unaccompanied youth, and then people who are trying to attempt to flee the domestic violence situation. So for street medicine patients, they're either sheltered, unsheltered, or housing insecure. And how I loosely define housing insecure is when the team goes to New Journey Community Outreach at their food pantry, if people are having a hard time securing food on a frequent basis, to me, they're housing insecure. That means that at any moment they could also lose their housing. So that's how we loosely define it. And it's really important for us in healthcare to understand the difference between equal access to healthcare and equitable access to healthcare. So for a large part, our system is really based on equal access. So if you walk into the emergency room, you can get treated, right? That's equal access. But does your provider understand that you may have some social issues that may preclude you from participating in your own healthcare, whether it's your mind is focused on housing or insecurity or domestic violence or transportation or income? You really can't make your healthcare or your health a priority. And so equitable care is really taking each individual as they are and providing care based on where they are today. And so it's really kind of flipping the script and meeting patients where they are. I saw this graph during an implicit bias training, and I thought this was the best way to talk about the difference between equitable care and equal care. So key things that we look at in terms of what are barriers to care, because that's essentially what street medicine is doing, removing any and all barriers for our most vulnerable population. And we do that really by studying our population. And what we've learned from our needs assessment is that barriers to care include out-of-pocket expenses. So people avoid going to the doctor because they don't know what they're going to have to pay. Not being able to navigate the healthcare system. If you think about your own experience, when you need to make an appointment, you call, probably leave a message, someone calls you back, and then you have to make an appointment within banker's hours, so between 8 to 5. And so for these patients, that doesn't really work for them. Lack of healthcare insurance is a barrier, but for street medicine patients, not having insurance is not really an issue, which tells us that it's really our structural system is what causes the barrier. Long wait times, and then cultural barriers. And then, so that's just for the population. So people who are low income, minority, but when you add on top of that homelessness, you see those other 5 additional barriers. So all of these things together make it very difficult for homeless patients to access the healthcare system. And that's where street medicine comes in to remove these barriers and really help the patient focus on their care. So street medicine, this is our new structure here. One thing to note, that the program is 100% supported through philanthropy and grants. And just recently, we received a very generous donation from the United Way, which allowed us to add to our team. So prior to our grant from United Way, we had one full-time staff person, and then the physicians and other support staff, they're all volunteer. With the grant that we received from United Way, we were able to add 2 additional team members, and that will be a clinical director and a program coordinator. And this really just helps us to strengthen our program. It helps to support the volunteers and the clinicians that take care of these patients, but it also helped us to expand our care environments. So prior to the United Way grant, we had one full-time staff person and then a host of volunteers, and our care environment was really just the community. With the United Way money, we're able to expand the care environment to an inpatient consult. So as patients come into the hospital and they're identified as homeless or housing insecure, we'll have a staff person that can go and talk to that person and really to better understand what's going to happen to them once they discharge. And that will lessen the likelihood of them being readmitted, and it could also shorten their length of stay. And there's been a lot of studies around the country and even within Pennsylvania that have noted that when you have this type of inpatient consult program, you see a dramatic decrease in length of stay and readmission, and that saves hospital dollars. Prior to this, about a year ago, we looked at a cohort of street medicine patients, and we looked at their emergency room visits before their encounters with street medicine and after their encounters with street medicine. And what we noticed with that, just that one small cohort, once they started to be seen by our street medicine team, their ED visits started to decrease, and we were able to save approximately $1 million. So we knew just based on that, if we could get that inpatient program, we could save a lot more money. And then the third environment is a virtual clinic. And that equipment will be placed at Hope Rescue Mission, and the residents there will be able to use that telemedicine equipment to have a virtual visit with a physician or a nurse practitioner. And here's just a photo of some of the one of the vehicles that we purchased with one of our grants. And here's another one of about maybe 3 years ago, we received a grant from the Friends of Reading Hospital to purchase vehicles. The other thing that our grant funding goes towards, in addition to staff, is of course, vehicle maintenance, any type of supplies, equipment that the physicians or providers may request. We used to do a lot of food and toiletry kits. Essentially, anything we need to operate the program is donated or grant funded. Other thing I'll say before I pass it over to Dr. Luber to talk about a day in street medicine is the street medicine team, because they're so familiar with the patient population and can speak to it so well, they can respond at a moment's notice to emerging needs. And a couple of years ago, when the hurricane hit and we had a lot of people who came from Puerto Rico, ended up in Reading, the street medicine team was able to respond immediately and start providing clinics at Central Hispano for all those people that left without anything, without medication, without a provider set in place. They were able to respond and take care of those people. And then most recently, as Reading Hospital looked at providing better, more equitable access to the COVID vaccine, the street medicine team led that effort. Using their volunteers and really the street medicine strategy to get out and reach vulnerable populations. So with that, I'm going to turn it over to Dr. Luber, who'll take you through a day in the life of street medicine.
Thank you, Disha. And I think Disha does a wonderful job of being able to give such a great overview of our program at large. What I want to spend a little time talking to you about is some of the care specifically that we provide and the places we go to and some of the people that we encounter. So the type of care that we provide is very diverse. I would say that the actual medical side of what we do as physicians is maybe 50%, and the other 50% is the social aspects and trying to regain the trust of a forgotten and fearful community. And so the types of physical things that we end up treating go into two categories. One of them is the acute care items, such as muscle and joint pains, respiratory illnesses, asthma, COPD exacerbations, maybe even diabetic foot infections and things of the sort. So we see a lot of those acute minor things. We also see a lot of the acute, we ran out of their medications, maybe they just were released from incarceration or moved from a different town, maybe they are a new immigrant and they just don't have access to the medications that they once were provided by a physician outside of our community. From the chronic care, we treat pretty much anything, hypertension, diabetes, tobacco, substance abuse, psychiatric illness, which is a very prominent issue among our population. And they have a really hard time being able to connect with a lot of our community psychiatrists or even have access to be able to see them on a regular basis. So we have a psychiatrist that comes out with us on a routine basis and along with a substance abuse physician, both of them volunteers to help with some of that population. And of course, all of us as volunteer internists help to manage those conditions independently as well. So the real goal of these medical care initiatives are to fill the gap. We're not really meant to replace anybody as a full-time primary provider, especially because we are a volunteer, but rather to be able to gain increased trust in the healthcare system with our population, remove some of the barriers of being able to access that care, and connect them to the community resources that they may not be otherwise been able to connect to previously. The 4 sites, there are 4 main sites that are sheltered, which we go to on a regular basis. We're going out in a community once per week as a team, whether they be daytime sessions or evening sessions that they alternate. And those 4 sites that we've been able to develop as regular places now are City Lights, YMCA, New Journey, Soup Kitchen, and the Hope Rescue. And so it really gives a diversity across our community population of the homeless, including adult females and males. Hope Rescue is predominantly males as of right now, and they will be opening a women's wing, hopefully within the next year. COVID's delayed that a little bit, where we should be able to see a more specific female population there as well. So when we go to these sites, we also intermittently will go to some of the homes of people who are recently housed. So they may have been homeless, like one of our patients for over 13 years living underneath a bridge, and now they have a apartment that was able to be subsidized and filled in from some of our community connections. So we go to visit those people because they need continued supports even though they have a roof over their head right now. We still do, on a less frequent basis, go out to the bridges and into the woods and areas like that. But we found that over time, in the maturity of our program now, that many of those people may not be ready to connect with us. And so we don't really go there as frequently as we now go to our housed sites. And they know that we are part of the community now. We've become integrated enough in this population that they know where to find us, and when they're ready, they usually will seek out. And many times their first time in connection with them is nothing medical at all. It may be providing a hygiene kit or a food kit, or just checking in to say, hey, if you ever need us, here's our card, here's our phone number, reach out to us. Some of the things that we bring out with us when we go to these weekly outings, of course, our medications. We have over-the-counter and prescription medications. As Disha mentioned, most of our patients do have insurance, but the copay even of $1 or $2 may be too much for them. So we're able to provide, in most cases, up to a month of medications that we carry in backpacks with us. We also document everything in our computers. We have hotspots and are able to look at records they may have in our health system or other health systems locally, and be able to make sure that we're communicating that to other doctors they may ultimately be seeing when we connect them to our other resources. The basic supplies that we bring out, they're going to vary also based on the season. So right now we're in the hot season where bug sprays and sunscreens, hats, socks, those kind of things are really needed. But in the winter, we also bring out blankets and other food supplies and gloves, those kinds of things to help with the colder environments. As we're going to be transitioning into some newer programs as we get more staff, we are really looking forward to not only having the virtual kiosk to be able to have more regularity on a day-to-day basis as opposed to just a once weekly basis with our patients, but also we're looking to have some increased screening opportunities by doing eye care screenings and referrals, as well as podiatry and foot care, especially with our diabetic population. So that's kind of an overview of what our day in the life is. I can say it's definitely one of the most satisfying and fulfilling aspects of my job. If I did not have this volunteer aspect of what I do, I think it would be a big part of my heart missing. So I'm very grateful to be able to do what I do. And with that, I'm going to actually hand it over to Dr. Donato to tell a little bit of a patient story of some of the people that we encounter, because they are amazing people with amazing backgrounds, and you can put it to life a little bit for us.
So we could probably tell you a lot about stats, number of patients seen, number of meds prescribed, but I think what's probably more important is for you to hear a story. If any of you have been to Shell's Golf in the past, I guess 15 years, you probably know someone that we take care of. I'm going to call him Ken. Ken was married at one time, and when that broke up, his untreated psychiatric illness became an issue. He is chronically schizophrenic. He believes he's Jesus. And he won't take medications because when he does, he feels less close to God. He no longer hears what he likes to hear. Ken spent essentially the first week of every month in a hotel. And when that money ran out, he actually spent it in Shell's Golf, which would let him sit there until he got into heart failure. And he would then spend the rest of the month in some amount in the hospital. And he had 55 admissions per year, every year, where he was in basically until he got his next check, did a hotel, and then repeat. He is an incredibly kind guy. He has a little bit of problem that he gives his money away too much because he'll give anything to anybody. But he has a major, what we call social determinant of health, right? These are the factors that really interfere with care that a hospital building can't provide. So I'd say one of the key things that Disha has really helped us do is we've developed partnerships in the city. And one of the main ones was through the Salvation Army, who helped us guide him to getting a rapid rehousing program. So we got him a place to live in October of 2019. I can tell you that Ken has not actually been hospitalized since October of 2019. If you could sort of wrap your head around how much the hospital was spending on this man. Now, I think Dr. Luber said it very well, that placing a roof over somebody's head is not nearly enough because homelessness is not a building. There's so many parts to it. Ken really needed his social circle, which is actually cruising the halls of Walmart. So he needed a way to get there and get back. He needed help with his medications, and we need to pry a cup of noodles out of his hands every time we go because he tries to put himself back in heart failure with what is an incredible assortment of the most salty foods on the planet that he's putting away every day. So we probably go to see him 3 to 4 times a month. And I would say of the medical things that I do, what I'm wearing a glove for is cleaning his place because he can't do the basics of, okay, trash goes in the trash can, but really just needs human contact. And I think the fact that we can go out, encourage him to take his medicines, help him with some very basic stuff, has allowed him to function in the community for the first time in now 63 years. You know, the kind of stories I'm telling you, his brother knows, and he knows, and now the 12 of you know, but someone like him, there's just not a place where where modern medicine has to help him. It takes people going out to him, figuring out what his specific needs are and tailoring that to him. Yeah, I feel incredibly blessed that I'm able to do what I'm doing in medicine, but it's great to help someone like him that I know if street medicine wasn't there, he would still be in this cycle.
And I want to add to that this gentleman has a picture of our street medicine team at Christmas time that is one of his most prized possessions, sitting on his desk next to all of his salty foods, which he loves more than anything. And it's we yearly go. He happens to look a lot like Santa in the winter time, and so he's very happy and proud of this. He likes to get a little Santa job because he does that every year. But he has it on his wall, and we decorate his home for him with all of his Christmas decorations, and it's probably the highlight of his entire 365 days.
Wow. I had to almost try to disconnect myself emotionally from listening to you a tiny little bit, because I would have been in full-fledged tears. You know, Dr. Donato and Luber, thank you so much for what you do every day, not only to care for the patients that can come to you in a more traditional aspect, but for what you're doing to provide compassion and care for the individuals who just can't seem to find their way and need a little bit of inspiration and hope. And so we thank you for what you're doing. United Way is so incredibly proud to have been able to provide funding to the street medicine program. And this is just one example of the incredible work that occurs day in and day out that people often don't think about. So we will open it up. Does anyone have any questions before we allow our guests to get back to their busy days?
I have a quick question. So I noticed that, just naming a number of the different partner agencies with United Way, Salvation Army, Safe Berks, and others. Is that kind of your primary method for making outreach to these individuals? I'd imagine it is kind of hard to target some of these populations just because, getting contact with them on a regular basis if they're not working with any of these partner agencies. So just curious as to, that sort of strategy in keeping contact with these individuals.
Well, we actually get referrals for identifying and seeing these patients from a multitude of areas. We may actually hear about them from the fire department, the police department, city hall, sometimes with the inpatient stay through the ER or even our observation units, from PCPs and the community, Berks Community Health Center. So we really get referrals to these patients from a multitude of venues. The 4 sites that I had mentioned that are our main physical contacts and we go to, they are where most of the population goes to access their food. And so we get a very large portion of them just by they happen to walk in and see us, and they may not have recognized before that they had a need or have reached out to one of these other community agencies to say, can you help me? Until they see us physically in front of them in a place they regularly frequent. So that's probably where we get majority of them.
Got it. Thank you.
Thank you all for your time today and for all that you do each and every day.
Thanks for having us. We appreciate
Yes,
that.
thank you, everyone.
Right back at you. Thank you.
Have a good one.
Thank you. Have a